Oncology seems like one of those specialties that is really kind of a downer. Like it is just a heavy specialty, and you are dealing with lots of patients who have potentially terminal diagnoses. So, is it as bad as it sounds? Are there good sides to it? Well, today I'm talking to a PA who works specifically in breast oncology, and she absolutely loves her specialty. And she feels like it is very rewarding and actually a very happy specialty, which is surprising, right? But she's going to tell us why she feels that way, what she loves about breast oncology, and kind of what her day to day routine is like. Hi, it's Michelle with the Medicine Couch. I really appreciate you joining me. I hope you find these videos interesting. The success of this channel really relies on you. So I would ask you to please, if you liked what I do, like the videos, to hit that thumbs up, subscribe to the channel, and more importantly, share it with friends and colleagues who may also enjoy the video. All right, let's hear about breast oncology.
My name is Anna Fooy. I'm a physician assistant. I graduated in 2021, and then I ended up deciding to go to New Hampshire to start my career in oncology, and it has been the best thing ever since.
Great. I am happy to have you here, and we're going to dive into your specialty of breast oncology. But I'm curious, when you say you moved to New Hampshire, did you move specifically for the opportunity, or were you just going to New Hampshire anyway?
It was a little bit difficult starting my career. The Metro Detroit area is actually quite saturated. We have multiple PA, NP schools, MD programs, all within a very close radius. And, a lot of places just were not hiring. And when this position came up, I felt like that was the type of medicine I really wanted to practice and really start honing my skills. It's been wonderful.
This is probably one of those areas of medicine where you see a predominance of one type of population.
Mhm.
We can't just assume that they're all female patients. So let me ask you that question. We know
Yeah.
men can get breast cancer. Have you had any male patients yet?
Surprisingly, I actually have. Even within my first, I want to say like 3 months that I was there, I probably had about two. And now by this time, I've probably had a good handful at this point. It's really interesting to have them and it mixes it up a little bit.
So tell us a little bit about your job. Like, what do you actually do on a day-to-day basis?
So I am one of those people that loves to get up really early. That's when I do my best work. So even though it's technically 8 to 5, I like to get there around 7. And if anyone is familiar with Epic, you have your in basket. So that's definitely one of my first priorities. And working in medical oncology, I have about a maximum of 10 patients that I'll see. And that can vary, of course. I typically do not see new patients. If time allows, I will go to the new consultations with the two attendings that I primarily work with. And if I can't meet them at that time and I have my other appointments, I will try to make time to meet them after because I'll eventually see them throughout their entire journey. And really our goal within what we do is we try to alternate visits, the attending and the PA or NP or APP.
Before you go on a little bit, I'm just curious, are you in like a cancer center, or is this strictly just an outpatient oncology practice?
It's a hospital-based academic center, and
Oh,
we're in the hospital, but it's on an outpatient basis. What we do for like our infusions for chemo and things like that, it's considered outpatient, but it is actually in the hospital, which is kind of nice because a lot of times you'll get those patients that come in and they're really, really sick, and you see their labs and you're like, something is not right, and you're able to send them over to the ER. I really do like having that benefit because it does happen fairly often with our really sick patients.
you're not doing the new visit. So what are most of the visits generally that you're doing?
Most of my morning will consist of the active chemo or immunotherapy patients. We need to make sure that those patients get seen first prior to starting their infusion. We need to make sure they're medically, clinically stable. We look at their labs. We see if they've had any other updated imaging. For example, trastuzumab that really targets the HER2 positive cancers. We need to make sure that their echoes are up to date because that's something that we have to check every 3 months when someone is on that medication. So that's another thing that we would look at. So On top of the follow-up chemo or immunotherapy patients, I will also see our long-term follow-ups, which are typically our hormone receptor positive patients that are either on tamoxifen or anastrozole or letrozole, those types of medications. And then my third population I would say that I have too is typically our active metastatic patients. And those patients they can either be on an oral kind of cocktail of different things, depending whether they're hormone receptor positive, HER2 positive, either triple negative or triple positive. So there's a lot of different kind of diseases actually within just breast cancer itself. And so with our metastatic patients, we're pretty much just monitoring and hoping that they're not progressing. A lot of these patients can actually live quite a long time depending on, of course, their specific prognosis and their receptor status.
Are you ever in on the meetings to decide treatment, or is that always done by the physicians and then you're kind of following through plan and keeping up with people?
I would say it's actually a little bit of a mix. Even though the attendings, because they're fellowship trained in oncology, hematology, they ultimately will have the final decision, which of course makes sense. But I will say the a really good time that we all collaborate is during our tumor boards. And our tumor boards are really interesting because we have all the different subspecialties that come to the table and discuss a certain patient's case, especially if maybe the treatment plan is not clear or if they have multiple comorbidities that might make the treatment plan difficult to come up with. There can be a lot of talks between our radiation therapy and our surgery colleagues. We also have pathology that sits in on it, as well as our genetics team, physical and occupational therapy. I'm probably missing some other folks too, but it's quite interesting to discuss these cases and really decide like what is the definitive next step for this
Yeah.
patient.
Do you guys meet once a week or?
Yes, so the tumor boards that we have are once a week, and they're about an hour. Because we're an academic research institution, we also sometimes will discuss different research trials that we think may benefit our certain patient population.
So when you have these patients, they're with breast cancer and you are handling like the medication side of it, and say they also need adjunct radiation therapy, or if they're going to go to surgery, how does that work as far as who keeps the patient? Does the
Yeah.
patient still stay with you when you follow and they keep coming back to you as they go through these different things, or does the patient get handed off to then surgery or radiation for a while?
I even have a lot of my patients, like spouses or partners, ask us that too, because sometimes in the mix of it, they feel like, well, whose patient am I? Like, am
Yeah.
I the surgery patient? Am I the radiation medical oncologist? And the truth is, it is a mix, but I do feel like the medical oncologist does steer a lot of the kind of decision making, or like, I think this would be the next best step, or this. And again, too, it'll depend. Are we doing neoadjuvant type chemotherapy, immunotherapy, where they have that up front before the surgery? Are we doing adjuvant therapy where maybe they had a small hormone receptor positive tumor that was node negative, and they're able to get that localized lumpectomy or partial mastectomy first, and then they come to us for their adjuvant treatment, and perhaps they might need that aromatase inhibitor therapy, the letrozole or anastrozole. And then they will also see radiation therapy at some point too. So it's a little bit of a sharing, I would say, of the patient, but I definitely feel like from what I've seen now almost in the last 2 years is a lot of the patients will ultimately want to defer to us because we do, again, a lot of that steering of the ship.
And so when the patients are having infusion treatments, I had a friend, or I have a friend who works in oncology, and sometimes his duties were just to be in the infusion area monitoring in case anyone's having any difficulties or reactions. Is that part of your schedule too, or does somebody else handle that?
It is. So that can be the tricky thing when you have, 10 patients scheduled and your second patient of the day starts reacting. I do typically run over there. I have a little bit more leeway sometimes to be able to be the first one to come there. And usually, how that looks is our wonderful infusion nurses will send us a secure chat, usually to both myself and the attending that I'm working with for that specific patient. And I'll usually kind of run over there, make sure their vitals look okay, make sure they're stable. And I would say almost 9 times out of 10, the nurses usually have already given the hypersensitivity reaction kit. And so by the time I get there, they're pretty much stabilized. And I usually like to try to wait about like 20, 30 minutes with them just to make sure things are looking okay. We know that there's some chemotherapies that patients react to more than others, such as paclitaxel, or Taxol is the brand name. That one is very, very known for that. And especially if a patient, if that's their first or second time they're getting the paclitaxel, usually I'll send a message to the nurses and be like, hey, just an FYI, this is their first one. Like, please kind of keep an extra eye on them. But no, it's really great. Like, as long as you have that really clear, concise, intact communication, a lot of the times the patients are pretty much okay by the time the provider gets to them.
If you're going to work in oncology, I'm getting the feeling that you definitely need to be somebody who's comfortable working in teams and likes to work closely with other people.
Yes. And it's nice to be able to actually collaborate. Like sometimes we, at least in like our workroom, we will sometimes have our radiation or surgery colleagues kind of right next door. And we can just pop by and say, like, oh, this is how Sally Jean is doing. And, be able to have that kind of one-on-one. And they'll be like, oh yeah, and they'll automatically remember that patient. And I really like that because not only are you kind of helping the patient, but you're also helping yourself learn more about that specialty too, and how they might look at the patient different than a medical oncologist perspective.
Right.
So I like that. I like that a lot.
Yeah. And it seems like a little bit more of a social environment, meaning that medicine can be very isolating. If you're
Sure.
working in like a family practice, you may have one or two other providers in the practice with you, but you mainly just interact with your MA and you don't
Yeah,
really get to interact with a lot of other people. So
right.
do they give you built-in admin time, like half a day or hours here or there, or is your schedule pretty much packed with patients all day, every day that you work?
I have an admin day. Mine is currently Tuesdays, for example, and I thankfully get an entire 8 hours. And it's helpful because you are able to work from home and be able to maybe attend to your own personal appointment. But, you're still somewhat on call, so to speak, more so during the day. I don't take call like on the weekends or after hours, thankfully, which is very nice. And that's why it's also good that we have fellows that help out with that piece. But yeah, the 8 hours is really helpful. I would say definitely to just like catch up, or like if you really want to have more dedicated time to call a patient that you've been really thinking about or you're really worried about them. That's also when I do those types of things too. I also do a lot of work in survivorship and trying to build that program for patients and what life looks like even after their cancer diagnosis. So I'm on a committee for that, and that's very near and dear to my heart. So that's also when I have a little bit more time to kind of work on those projects that we're doing there. But really, I try to pre-chart usually the day before. I build out my template so that throughout my day, I have some breaks in between for what I call like catch-up time, where I'm able to maybe finish that note on a patient. I'm just updating a couple things and I can hit sign and kind of move on and maybe answer some in-basket questions. I've honestly found that that has been very helpful. I really do make sure that I am, I'm done at 5. Like I really have to set that boundary because I have to be back the next day, and these are very emotional, in-depth conversations we're having. So I really try to make sure that everything is taken care of by 5 p.m.
So obviously that's a big thing you have to think about if you're going to work in oncology is the
Mhm.
emotional side of it because you're
Yes.
dealing with a lot of, pretty heavy diagnoses for these patients. And that was one of the questions I was just thinking of is do
Yeah.
you guys have palliative and hospice care as part of the team there or do most of those conversations fall to you?
I would say it's a little bit of a mix. We do have a lot of trainings within our hospital system called like serious illness conversations. And we do thankfully have our palliative and hospice colleagues also because they're like a little bit further away on the hospital setting. We'll usually send like an in basket message to them if we're just like, I think we might need to start either transitioning towards a hospice kind of discussion or even just palliative. A lot of patients may not completely understand what that means because they automatically think hospice. But I tell them anyone could have palliative care. And we also rely on them too for a lot of the psychosocial things that definitely come up, especially in breast cancer, because there is so much change that not only happens in your mind, but to your physical body and to your appearance. And leaning on the palliative team to help with also that and even manage pain in our metastatic patients is extremely valuable.
It's probably a great time to talk about the pros and cons of working in oncology, but specifically breast oncology. Talk about first of all the great side of it. What are the things that you really love about this specialty?
I will say the most wonderful part is that I get to work with women for a majority of our patients. When I was in my clinical rotations, I did a little bit of like GYN cancers, and I love that I was able to like very personally connect. We have the same body, like we have the same kind of parts that we're talking about, and these are very sensitive topics. And although thankfully I have never personally experienced cancer, I have experienced it on a personal level through friends and family that are very close to me. And I truly feel like that really helps when you're very empathetic with the patient, and that kind of leads into who might be really good for these type of positions. When you have
Right.
such a big heart, like you just want to exude that towards your patients. I mean, just building that connection not only on that kind of personal level with the patient, but then their family and their loved ones, you really get to develop this strong bond. And I just think that that is so wonderful for the whole like therapeutic relationship.
And I imagine that you have success stories too, right? It's not all
Oh
doom and
yeah.
gloom every day you go into
No.
work. Is that true?
Yeah. Yes, I would totally say that because so many people ask me, like, you work in cancer? Like, how can you do that all day? And I'm like, especially with all the advances we're having in breast cancer right now. Yes, we do have some young patients, and those are very sad. They're young mothers, young families. But I tell them, I'm like, this is the journey. We are starting this journey together, and my job is to get you through this safely and as healthy as possible so that you can live a very full life on the other end. So I think when you really like tell that to the patient and they feel like you are literally holding their hand through this and you are like one with their diagnosis in a sense, they trust you, and you develop that so that you can get them the care and the right treatment that they need. It's really beautiful to watch. I mean, there's really nothing like it.
Any cancer is a tragic diagnosis and hard for people, but breast cancer, especially because often it can lead to mastectomies or double mastectomies. The breasts,
Mhm.
they're just a part of the identity of a female.
Definitely.
So, can you talk about that, like that special part of working in breast cancer and the good and bad of that?
Yeah, it is such a personal, deeply personal decision. Sometimes the surgeons will have to maybe lead a patient one way or the other, mastectomy versus like a lumpectomy. And it's really interesting. These patients are so strong. They're so intelligent in these decisions that they make. And sometimes they will opt to have a reconstruction, whether it's with an implant or with something called like a deep flap, where you use another part of your skin to essentially graft that onto your breast, chest wall area. And some patients on the other end will opt to not have any reconstruction at all. And that's also really, really interesting too. And I've had patients also have beautiful tattoos placed where their breasts were.
Yeah.
And, they tell me this whole story of, this is why I had this there, and this is what this means to me. And I love hearing things like that. And it's so, so interesting.
I think it's interesting too. I actually interviewed a classmate of mine who works in plastic surgery, but specifically in breast reconstruction.
Wow.
And
Yeah.
she does tattoos, not the same kind of tattoos like you're talking about, but she'll do like the
The
nipple tattoo
areolar nipple.
reconstruction and stuff.
Mhm.
Yeah,
Mhm.
it's pretty amazing. And I'll put
It
that card up
is.
here if anyone's interested in checking out that interview. What about the downside, the bad part of working in oncology? Because not everyone survives or has easy journeys. So talk through that a little bit.
I feel like I am a very empathetic person, and I think patients that have oncologic diagnoses, they're such in a vulnerable space, and as this provider that sees them multiple times, especially if it's a metastatic patient where we're seeing them either every month or every 3 months, you just wanna do everything for them. And sometimes that is not always possible. You do need to learn to lean on your other subspecialties to help you because you still have, other patients to take care of. But I think that's one of my hardest things that I have noticed is you just want to be everything for them because you want to just take that like burden away from them.
But what about losing patients? Because I assume you've lost
Yes.
patients. How do you deal with that and not allow it to, I mean, it's going to affect you, but not allow it to overtake you with grief and let you still continue to do your job?
It's never easy. At times you do know that it might be coming. You see that they're week by week, they're doing worse, they're
Yeah.
calling in more, there's more and more problems, there are multiple ER visits, and you start to think, this might be we might be coming to the end. You don't always get that buffer or that time to kind of prepare, but I think kind of how I deal with it, I lean on my faith a lot, and I just think God or, whatever bigger spiritual being you believe in, they had a plan for this patient and they fought, they were with their family. We tried to keep them as healthy and happy as possible so they could have that normal life. And in the end, unfortunately, death is very much a reality. And just realizing that, taking that in, we also have a chaplain on staff that is amazing. And sometimes I will stop by her office and be like, I really need to talk about this. Like, this was really hard for me. I connected with this family, I connected with this patient, and they're gone. They fought so hard, and I think the other thing too that gives me a lot of solace is they are not suffering. That suffering has ended.
Yeah.
And what I typically will do as well, depending on if they're with someone or if they had a friend that was really close that came to their visits, I will usually call that person and give my condolences to them.
Yeah, and I imagine for you too, it's a little bit of bringing that case kind of to a closure to give you the time to express to somebody your feelings about this patient and not just holding it inside and being like, well, they passed away and have that kind of loneliness you get to share with somebody.
Right.
It's important to have somebody I think that you can talk to and kind of get that out a little bit instead of keeping it inside.
Yes, yes, it definitely helps. Like I'm a very talkative person and I need to be able to express my feelings and my thoughts on kind of an out loud basis. And we also tried to make sure we write a card for the family. We have everybody on the team sign it and we usually talk about it at our like weekly team meetings, patients that have passed, and we keep like an active list. But I will say I am so thankful that it is honestly not that it's not rare, but it's also not often. Like it's not happening like every day. And
Right.
that's why I
Yeah.
say there's just so much more hope in this field than people might realize.
Yeah, good point.
Yeah.
Yeah. Good to bring that
Yeah.
out so people don't think that they're always every day going to
No.
work dealing with death. And I'm curious about you're talking about PAs and NPs. Do you work with both PAs and NPs? Are there other PAs and NPs on the staff or is it just you?
So it was actually just me for a while as like a physician assistant. We do have some more now as far as like our APP group as a whole. But when I think back kind of like to the history of oncology, I think a lot of it was rooted in nursing initially. So I have a lot of wonderful nursing colleagues and then also nurse practitioners too that we work with. And I think sometimes maybe some people think that you necessarily have to have oncology experience to start in oncology, but that's not necessarily true. I think if you are open and willing and you have that passion, like that is really what I think people want to see is that passion, that love for your patients
Yeah.
and medicine in general. That is really what's going to drive you to have success in this field.
Do you work specifically more one-on-one with one particular physician, or do you work closely with several physicians?
Right now, how my job and the position is set up, I work with two main attendings. Like I'll have separate patients with one and separate patients with the other. And if I have specific questions or something I'm not sure about for that patient, I'll go to that attending, whoever they see. I think ideally in a perfect world, it would be best to just have one physician that you work with. Just because like you're kind of juggling two patient populations between two different physicians, kind of trying to remember, what they might like for this patient or for this diagnosis and things like that. But it does work out.
You said that you don't have to have experience to come into oncology, but did you have oncology specific rotations in school?
I did. I worked 5 weeks mainly with one physician, and we also went to tumor boards. He mainly did more of hematologic malignancies, and then he also did like GYN cancer. So it was kind of an interesting mix. And my other oncology rotation was more of a general hematology oncology. So I think definitely having that and seeking that, and if you know that you really want to do that, is very helpful to get those set up and speak up for yourself too with your clinical director in your school that this is something I really want.
So, if somebody is looking to get into this specialty, whether they're a new grad or they've been practicing for a while, what resources or references have you found to be most helpful to point them to?
I'm a really big podcast person. There is the ASCO Daily News, which is the American Society of Clinical Oncology. They have a lot of like breaking news on certain like trials or what things have been approved through the FDA. The ASCO Education podcast too, which is again very helpful. They talk about different disease processes, different cancer diagnoses. The other one I really enjoyed too is the breastcancer.org podcast. And also the Cancer Care Connection Education Workshops podcast. And so I think between those ones, I kind of have been able to gain a lot of knowledge, especially using the NCCN guidelines, which is essentially our Bible for oncology and the different chemo immunotherapy regimens or, which kind of algorithm to go down depending on that certain patient. As far as books, the one that has really stood out to me is called The First Cell. It's amazing. It's actually by a hematologist, and she just speaks about how much more progress we really do need to have in the oncologic hematology world with cancer. And we are essentially giving our patients this slow poison. Is there something we can be doing better? These new targeted therapies or these individualized treatment plans for these patients and what's going to be the least toxic. I love that book. And then as far as from like an organizational standpoint, there is the APPOS, which is the Advanced Practice Providers Oncology Summit. And they have lots of conferences that are actually pretty affordable. I also really like the APAO, the Association of PAs in Oncology, and then, of course, the APSHO, the Advanced Practitioner Society for Hematology and Oncology.
And that makes me think too that people may not realize that cancer is probably a pretty exciting field to work in. Do you see a lot of new discoveries, technological breakthroughs, and things coming that are going to revolutionize cancer?
I really think so. As more so speaking from the breast cancer standpoint, 1 in 8 women in their lifetime have that risk of breast cancer. So a lot of these different organizations are really motivated to find different treatments, the new, the greatest thing, the different like clinical trials. My interest is really in the hormone receptor positive metastatic population because I have some patients that are living 20 years out from their original metastatic diagnosis and they are living normal lives. I mean, it's amazing. They're
Yeah.
traveling, they're professors, they're lawyers, they're doing all these wonderful things and it's becoming more of this chronic disease that we're managing and once we get them stabilized and optimized on their specific treatment, these patients can do quite well. So it will be just so interesting to see what else comes out as far as treatment or even de-escalation of therapy is another big thing too. I think of things like the tamoxifen. The standard of care right now is 20 milligrams, but there's studies out there like, are we giving too much to women? Do we need to decrease the dose? And that will that still prevent them and protect them from cancers? It's amazing. Like I just think that it can only grow from here.
If you're interested in the field of oncology in general, then you might want to check out this video here. Thanks for joining me, and as always, take care, stay sane, and I'll see you next time on the Medicine Couch. Bye.